Hi, everyone. Welcome back to our lecture series. Today, I have combined labor and birth and nursing management during labor and birth. This is chapter 13 and 14. And let's get started. So when we are looking at nursing management, what do we as the labor nurse, what is our role? We have a multifaceted approach here. Our job is to know what's normal and then to assess and recognize what's not normal, and then to educate about the process to the birthing person as well as the family, to offer comfort measures, both non-pharmacological and pharmacological. And I think one of our big shortcomings in nursing, in my opinion, nowadays, is we are not taught about non-pharmacological. We focus on the pharmacological. We're there to give emotional support. We're there for intervention, like I said, early recognition. We are advocating for what the patient actually wants her experience to be. We are the eyes and ears of the provider, either a physician or a midwife. We're usually the one at the bedside that sees the progression, and we're also support and an example for the partner or family that are involved in there. So when we talk about assessment, we have our admission assessment and then our ongoing assessment, and those two we will discuss the differences in as we continue on. So what actually causes labor to start? We're not 100% sure. We know that it's a combination of all of these factors: the stretch of the uterus, there's progesterone withdrawal as that placenta starts to age. We have an increased oxytocin sensitivity, oxytocin being the natural hormone that is produced by the pituitary that causes uterine contractions, also causes that milk ejection reflex. And then we have an increased release of prostaglandins based on the pressure on the bottom of the cervix and the stretching and pulling as that starts to open. So it's a combination of all. And this is just a picture, kind of the feedback loop of how this all works. But we don't know. We know it's a combination of fetal factors and maternal factors. And so just take a minute here and look at some of the, put into your mind some of the things that I just mentioned. So here are signs that labor is coming. It doesn't mean that it's going to happen today. It's just signs that the progression is happening. We're going to start seeing lightening potentially. This is when the baby settles down into the pelvis. Some people say, oh, your baby's dropped. Well, as that baby starts to settle down into the pelvis, we know that it's going to put more pressure on the cervix and things are starting to move that direction. Sometimes there's an increased energy level in the mom. We might see some bloody show, which is a little bit of bleeding when you wipe, or maybe a little bit of bleeding in our underwear. And that is a little bit on the toilet paper or when you wipe is okay, but bright red running down your leg is not okay and needs to be evaluated. So we need to educate our moms what is normal and what is not normal. And this is just from the stretching and thinning of that cervix and that mucus plug that is starting to dissolve and come out. We might have some Braxton Hicks contractions. These are contractions that we can feel. They're not super effective, but it's all practice. And we've actually been having Braxton Hicks contractions for many months. You just because the uterus is not as sensitive to the oxytocin, you don't feel them as much. And most likely because the uterus is not as big. There might be a rupture of membranes. This doesn't happen very often, that breaking of the amniotic sac and the fluid coming out. Sometimes it's with a leak and sometimes it's a gush that may or may not happen. Only about 10% of women have that happen before they actually go into labor. And then the cervix is going to start to change. It's going to soften and it's going to possibly start dilating depending on whether mom's had babies before or not. And all of this is a sign that labor is coming. It's not a predictor, it's a sign. So how do we know true labor versus false labor? And your book spends a lot of time here. I'm going to make it super simple. If you're having contractions and they are changing the cervix, either thinning it or starting to open it, then this is labor. Now, labor can come and go. It depends on the environment. Sometimes women need a nap and then they are refreshed and can continue on. So there's lots of nuances that contribute to how a labor is going to go. And I'll talk more about that in a minute. So when you're timing a contraction, you start from the beginning of the contraction to the beginning of the next one. And we call that frequency. And then the duration is how long they're lasting. So from the beginning of one to the end of that same one is the duration. Why do we get all caught up in timing them and talking about the duration? Because we can kind of predict what stage of labor someone's in based on what their contractions are doing and based on what their cervix is doing. Now, early labor, that first, for most people, the first 12 to maybe 16 hours, that early phase of labor, the best place for them to do that, if they're in the low risk category, is outside of the hospital. We need them to be at home. This is where they're going to be more comfortable. They can sit in their favorite chair. They can eat what they want. They can drink what they want. They can sleep where they want. They can take a shower in their own shower. So giving women tools to stay home as long as possible is essential. Now, we have to know what our warning signs are, because if we have any of those warning signs, we need to head in so that we can get a higher level of care and be taken care of that way. So we're going to talk about the P's of labor, passageway. That's where the baby has to pass through. The passenger, obviously the fetus and the placenta. The powers, which are the contractions. The position, maternal and fetal. And the psychological response. That will be essential into how well this mom is handling her labor. A couple more P's. The philosophy. Does she have a high tech, high intervention philosophy, or does she have a low tech, high touch philosophy? And where is she giving birth? What's their philosophy? These things will influence this labor. Who her support persons are, patience, understanding that each labor is unique and each woman is unique and each baby is unique. How well prepared she is. Does she know what to expect? Does she know what's coming next? Does she know normal versus abnormal? And pain control, what she chooses to use for comfort. So when we're talking about the passageway, we need to talk about the pelvis, because this is where the baby is going to come through. And so here you have some pictures of the pelvic brim. This is what we call the greater pelvis. And then down below, if you were to look at it from upside down, that's what we call the true pelvis, because that's where the baby actually has to pass through. We have 4 different types. I've talked about this in another lecture. Our most favorable for vaginal delivery is gynecoid, but we don't always know what type of pelvis someone has. An android is typically not favorable. An anthropoid is usually adequate, and a platypuloid is not favorable. So not favorable doesn't mean it's impossible. It just means that it's harder for the baby to navigate this true pelvis. We also have to think about our soft tissue. So the cervix, which is the bottom part of the uterus, has to thin through what a process we call effacement. And it also has to dilate, open, a process called dilation, and sometimes you'll hear it pronounced dilatation, means the same thing. This is to allow that baby to slip through. I like to think of it like a turtleneck sweater that has to slip over that baby's head in order for it to navigate the passageway. We also have the pelvic floor muscles, and then down through the vagina. And this is a little, just a picture, a description of how these things are working. So that cervix starts off super thick, like your earlobe. Everybody touch your earlobe. And then it eventually becomes very thin, like the skin between your first finger and your thumb. So effacement is going from that super thick to that very thin section. And that is a muscle. So it's muscular contraction that causes that to happen. And then it also has to dilate, open at the same time. It starts off what we call closed or fingertip, where we can just put our finger in it. You've seen that in some of my other lectures where you see what the cervix looks like. And eventually it has to open up wide enough for this head to slip through. And that's, if you spread your first and second finger as far as you can spread them, that's how big that opening will need to be. And I like to describe things in terms that women will understand. If I say you're 4 centimeters dilated, that doesn't really make sense to a lot of people. But if I say your cervix is open to the size of a banana and it needs to be the size of a cantaloupe, they understand how far they are in labor. So good diagram here. Again, it's just showing you not effaced, not dilated, fully effaced, not dilated, and then fully effaced and fully dilated. Now, this is what we're doing as a labor and delivery nurses. We're actually going in with our fingers and measuring the thickness of the cervix. So it has to be open a little bit for us to determine that, and how open it is. This is a predictive tool that a lot of people put a lot of stock into, and I'm going to tell you this changes very rapidly. This is actually just a sign of how effective those contractions have been. It's really not as predictive as we make it out to be, but it's become the standard of practice that we do vaginal exams to, quote, determine the process of labor, determine where they are in labor. And it's very invasive. A lot of women find it extremely uncomfortable and don't like it. And women do have the right to refuse this because it doesn't really do anything except give us some information and help us, satisfy our curiosity. Now, every intervention potentially has risk. So even though we wear a sterile glove, we are going through a non-sterile area up to where the baby is. So there's always the potential, especially if the membranes have ruptured, for infection to be pressed up there into this baby. Again, just another picture of what we're measuring, and this is subjective. So everybody has a little bit different size finger. And this is something that you learn once you're out of nursing school. We don't do this as nursing students, but once you're out of nursing school and you get hired into the unit, you will work with your preceptor to learn this assessment. And this picture actually shows this woman with some long fingernails, and that is a big no-no in labor and delivery and working with NICU babies, because you have bacteria underneath these nails that can harbor bad bacteria that can cause extreme infection. And so every place has the rule that you cannot have artificial nails and they need to be kept short. So the passenger, we're going to talk about all these different things: the skull, the attitude, the fetal lie, presentation, position, station, and engagement. So this is just this is available on Etsy, and it just is another tool to help teach how big this dilation has to get of the cervix in order for the baby's head to slip through. So when we're talking about the baby's head, this is what makes us human. We are unique in that we have these 4 bones, 1, 2, 3, and 4, that are not fused as a fetus. They have these openings in between them. These are the large areas that will eventually fuse, are called fontanelles. There's an anterior fontanelle and a posterior fontanelle, and they have a different shape to them. And if you've ever wondered how we know what direction the baby's facing after we've done an exam, it's because we felt the fontanelle and we can tell how the baby is coming into the pelvis that way. Eventually these will harden up and become solid bone, but right now it allows these bones to mold, a term you need to know, on top of each other and fit through this opening. That's how we do it. We have these big heads because we have these big brains, and then we have this smaller hip structure and pelvis structure because we walk upright. And so those two had to figure out a way to work so that we could still birth babies. And this was what nature came up with, is to have these bones that slide on top of each other and allow the baby's head to come through. Sometimes it can be very pronounced. This is a very pronounced cone-shaped head. You can see there's all this redness is going to be bruising. May have even had a vacuum on. It looks like there might be some skin. Maybe, I'm not sure. The picture is a little hard to tell, but this is going to be back to normal without us doing anything, going to be back to its normal shape within just a few hours to a day or so. This is a normal process and it's meant to happen this way. So the attitude is the relation of the different body parts, so the head and body of the fetus to one another is called the attitude. And so we have the universal attitude is flexion. We like them to be nice and tucked up so that this head will fit through the pelvis in the best, most conducive way. There's flexed, deflexed, and extended. I'll show you a picture of that. So here you can see the widest part of the head is fitting through the widest part of the pelvis, which is nice. It works really well. And so this is completely flexed with the chin tucked. And then here you can see as we start to have extension, and it's not tucked in, it makes for a wider diameter and it makes it harder to fit through. And this face presentation, this is what it looks like when it comes out, is it can happen. Babies can be born that way, but they are at high risk for bruising. And, we do see issues with these babies not fitting well in these ways. So we like them to be nice and tucked in. When we're talking about the fetal lie, we're talking about how this baby is positioned inside the mother. So vertex is head down, breech is butt down, and notice it's breech, not breached, with an ED on it. And then transverse is sideways. So you can see that this baby is not going to fit through this area. So we want them to be vertex. There are still some providers and practitioners that will deliver vaginal breeches, but there has been some study into that, and it does appear that they are at higher risk for injury from a breech delivery. There's a very slightly higher risk. And so most physicians have opted not to do breech deliveries anymore. You will still find some midwives that will do them, and depending on their state, whether it's in their scope or not. But most breech deliveries are, they schedule them either for aversion, trying to turn them, or for a cesarean section. And then here are the different fetal presentations that we can have. Remember, we can have our cephalic, which is vertex, head down, and they can be military, brow, or face, and this is based on that flexion that I talked about. And then for breech, we can have frank, full or complete, or footling. And so these are all just different types of presentations. And then you can have that shoulder presentation. So you don't have to memorize all of this. I want you just to get an idea of some terms that you might hear when you're in clinic. And here's another picture of all the different things I just talked about. Okay, and so another term you might hear is where we talk about the fetal head in relationship to which direction it's facing in the mother. So here you can see we have a right occiput posterior. So what that means is the occiput posterior is facing to the mother's right, occiput being that occiput bone in the back. And then here we have a left occiput posterior. So now the back of the baby's head is facing to the mother's left. What we really like, is for this baby to be ROA or LOA. These are the best possible ways for this baby to fit down through that pelvis. We want them to be facing the mother's back. So here you can see the baby is actually facing towards the front of the mom, and that makes for a wider diameter of the head. So occiput posterior is one of those positions that we try to help the mom change her position and encourage the baby to turn around, because it's easier to deliver. If you've ever heard someone mention, oh, they had extreme back pain during labor, most likely it was because the baby was in one of these two positions. And I'll show you why in just a minute. The other thing we talk about is where the baby's head is in relationship to the ischial spines. So you can see if the baby is right at the level of the ischial spines, we call that engaged. That means it's come down into the pelvis and it's getting ready to start the descent on its way out. So we quantify this in numbers. So here we are at 0 station. This means the baby's engaged. Any negative number means the baby's still pretty high up in the pelvis. And any positive number means the baby's coming this direction. So you might hear somebody say, my patient is 3, 100%, and -2. So what they're describing is my patient's cervix is 3 centimeters dilated, it's 100% effaced, and the station of the baby is still pretty high up. And the reason why they would give that information, say in an SBAR report, is because it is a predictor of what stage of labor she's in and what phase of that first stage. So if I say she's 300% and -2, I automatically know she's got some work to do. She's in that early phase of labor. So this is a revolutionary concept. Spinning babies, I'm not a spinning babies instructor, I'll put that out there right now, but I've gone to several classes, and this was created by a midwife, and she really wanted us to go back to some of that old knowledge that we seem to have lost as labor and delivery nurses. And navigating the pelvis is most of what happens during labor. The cervical dilation and effacement is really just a reflection of how well this baby is navigating this pelvis, because those things go together sometimes. So one of the concepts in spinning babies is we want to think about, where is the baby? Because as a labor and delivery nurse, I know that if the baby is in the inlet, way up high, I've got some things to do to help this baby get into the best, most optimal position for delivery. And again, if it's in the mid pelvis, I have some tools that I need to use to help this baby get down through and navigate its way out. And then the outlet, I've got, again, I have some goals. So great slide. Highly recommend, if you plan on working in OB, you will need to take a Spinning Babies course. This is one of those continuing education courses that's not required by the hospital, but required to be an effective, efficient practitioner. Leopold's maneuver is something that you sometimes will hear mentioned on NCLEX, and so you want to understand what we're doing. We're actually using our hands to try to determine where this baby is. Now, it might be hard to do if somebody is a higher BMI. It might be hard to do if you have multiples. It's going to be difficult to do if you have a small baby and a lot of fluid. So you're not going to get proficient at this during these next few weeks, but I just want you to understand what it is we're doing when it's an actual technique that we're utilizing when we are touching that mom's belly. And so another way that you can do it is ask the mom. This is the key to belly mapping, which is Spinning Babies, modern day version of the Leopold's maneuver, is asking the mom where she's feeling those kicks. Follow the clues. Where are you picking up the heartbeat? So this is a great slide to spend some time looking at. These are the cardinal movements of birth. Every human being that has come through a vaginal passageway has had to do these cardinal movements. I'm not going to ask you to memorize them. Sometimes you'll see a NCLEX question about it, not very often, but all of these things have to happen in order for this fetus to navigate through this pelvis and be born. It's kind of amazing that it works as well as it does, as often as it does. So now we're going to move on to the powers. These are our involuntary uterine contractions. We get a stimulus that comes from that stretching and pulling on the cervix. That is on a feedback loop, sends a message up to the brain. The brain says, oh, we need more oxytocin here. Let's help. We're going to continue this rhythmic contractions that get closer together and stronger as the labor progresses in order to get this baby out. So these are involuntary, like I said. I always find it interesting to listen when a woman gets to the point of it's time to push her baby out. If she's unmedicated, she has an involuntary reflex to bear down and push this baby out. And us standing on the sidelines telling her to push or not to push is irrelevant. Whatever we're saying is not helping this mom, because these are involuntary responses. This is what a modern day hospital room looks like, and what you often see women attached to this electronic fetal monitor. and I'll explain more about that. And I have an entire video, and you're going to have to spend some time over there looking at that. But these monitor parts are here. They have wires that come over to the monitor. There are wireless Wi-Fi monitors with varying degrees of effectiveness. But this is what you probably will see when you're in clinic, is a mom that's getting continuous fetal monitoring in bed. And this information is also being displayed to a central monitor, and that allows this nurse to be able to take care of more than one patient. So you've got a monitor on the top called the ultrasound, and a monitor on the monitor on the top called the toco, and then a monitor on the bottom called the ultrasound. Now, fun fact, if you have a baby that's in a breech position, we will probably have to reverse those, and we might have to find heart tones up top with the ultrasound. So it depends on the baby's position, but this represents the fetal heart rate, and this represents the movement of the uterus. And so as it contracts, as that muscle contracts, we can pick up the movement on the uterus. You can put your hand there and actually feel it as well. And it just tells us how long it's lasting and how frequently they're coming. It does not tell us strength. It's impossible for this monitor to tell us how strong these contractions are. Now, the nurse can assess it by putting her hand on top of that fundus and feeling if it's mild, moderate, or strong. And the patient can tell you whether it's mild, moderate, or strong. But the only way to tell, to have an exact measurement of the strength would be have an internal monitor. I'm going to talk about that a little bit later. So when we're looking at our uterine activity, I already mentioned when we are counting contractions, we look from the beginning of one to the beginning of the next. And then you can also look at how long they're lasting from the beginning of one to the end of that same one. So frequency, how often they're coming, duration, how long they're lasting, intensity. You cannot tell intensity from an external monitor. You can palpate it with your hand, or you can ask the mother, but intensity cannot be determined from an external monitor. And then how long of a relaxation. And with our new guidelines that have come out with fetal monitoring, we've known this for years, but the new guidelines that just came out, they say we really need to be paying most attention to how much of a relaxation period we have. Okay, we're going to move on into our nursing care of our first stage of labor. So when she first comes into the hospital, we're going to ask those privacy questions. I've talked about those in a previous video. We're going to get her admission history. What brings you in today? What are the signs and symptoms? What's going on? If your water broke, can you tell me the color? Can you tell me the time? And how much amount? Was there odor? Were you in the last time you were checked by your provider? What was your cervix dilated to at that point? Is there any medical problems I need to know about? Has there been any issues with the pregnancy? Blood pressure issues, blood sugar issues? Do you have any medical problems outside of pregnancy I need to know about? We're going to obtain a really thorough admission history. And then we're going to look at her prenatal labs. And once she gets admitted, there'll be a series of labs that we're going to do for her baseline information. Did she have any childbirth education? Does she have a birth plan? And if you will hear lots of jokes about birth plans, lots of memes are put out about birth plans. And as a modern day labor and delivery nurse, if you have a problem with a birth plan, then you have a problem with informed consent, because women have a right to choose. And as long as they've had good education and are making logical decisions based on that education, then we need to support that. That is our role. It is not our role to tell somebody how to have their baby or what's to be expected. We have to support what they want. They've hired us to take care of them. And then we're going to complete a physical assessment. So back to basics, this is one of the things I worked on when I completed my doctorate, is that we really need to be giving great information to moms before they come in during this phase. And then we need to give them options. We know that we can decrease our C-section rate by keeping people that are in that low risk category out of that hospital as long as possible. We know it, it's a fact. The longer they stay home, the more of that early labor they do at home, the better chance she has of having a vaginal delivery. And so this is just one of the protocols that I created. So here's some of the things that we're going to be looking at with our admission assessment. We're going to be obviously getting vital signs, heart and lung sounds, height and weight, any body system that has a specific issue. We are doing a focused assessment. For the most part, the women coming in having babies are healthy. And so we aren't going to do a full physical assessment like you would maybe in the med-surg unit, but you are going to take a quick peek at all of the systems. You're going to do that fundal height measurement. We talked about in another video how you're going to do that. We're going to assess that uterine activity, what's going on there. I already talked about the status of her membranes. We may do a cervical dilation and degree of effacement. We are going to be listening to the baby's heart rate, determining the position using that Leopold's, potentially station. We'll do that along with doing that cervical assessment. And we're going to be looking at her pain level and how well is she coping. So here are all the things that we're going to look at in her prenatal records. It's important that we have this information. If we don't, it is our job to get them. Meaning either we get the prenatal records, if she doesn't have them with us or they haven't been provided by the provider, we need to call, send over their appropriate consent forms, get that information because it's going to contribute to her care in the hospital. And if she has not had any prenatal care, we're going to have to draw all these labs. Some of them are not going to come back right away. So there'll be a decision tree and things we have to do if we don't have the answers to these questions. We're also going to be doing a CBC and a hold clot. Most facilities use that as a baseline, so we know what she was before she delivered. And depending on where you live, you may be doing a third trimester syphilis screening. If you live in a high-risk area, the day of delivery, we want another one. As nurses, we're going to be performing some assessments to figure out what her bleeding risk is. Every woman has a bleeding risk, so it's not yes or no, it's low, moderate, or high. What her shoulder dystocia risk is, again, it's either low or high, and if she has any signs of preeclampsia. So other things that are going to influence whether she has a positive experience or not. They've done extensive research into what makes a positive experience. And believe it or not, it's not always the outcome. It's how she was treated during labor, whether she had support, if she felt a sense of mastery and self-confidence about the process, if she had trust in the staff that was caring for her, if she wanted the pregnancy, if she had personal control over her breathing and her actions, and how well prepared she was. So this is what we see in the media, right? This is what you're used to seeing. These are all pictures of people that have portrayed giving birth in the media, and we're used to people being angry and mad. And if you get close to them, they're going to bite and kick and punch, and it's terrible and it's a horrible experience. And I'm not going to say those things don't ever happen, but it's not the norm. Here, the following are some pictures that were all put out on the internet. So I have gathered them from several places, and these are all pictures of people that are delivering their babies in a calm, loving, supportive environment. They are feeling powerful. They are feeling empowered. They are feeling supported. You can tell by the looks on their faces. They are feeling victorious. Do not confuse power and victory with pain. This is, I would say, this is overjoyed. This is overwhelmed. This is powerful. This is a woman having a cesarean birth, meeting her baby for the first time, also overjoyed. This woman is feeling empowered. Sometimes you see shock, sometimes you see surprise, and sometimes you see joy. And this was a photograph of the year. This is a little one that is meeting her sibling just as it's born, obviously in this pool. Okay, so how does our bodies change in labor? You have to know what's normal in order to know what's not normal and be ready to report it. So we do have an increased heart rate. We do have an increased oxygen consumption. And sometimes you will see an increased blood pressure during contractions because that uterine muscle is causing excess pressure against the vascular system. We will see an increased white blood cell count, which is why everything's different in OB, and you have a different range when you're dealing with a pregnant and or laboring woman, mostly laboring woman. We have decreased gastric motility, meaning as if she's eaten a giant meal, her body may decide to get rid of it rather than continue digesting it because it's got to use its energy doing something else. Sometimes we have a slight temperature elevation. There might be muscle aches and cramps and decreased blood glucose levels. So let me ask you this. If we have decreased gastric motility and food absorption and increased muscle activity and basically our bodies are running a marathon, and increased respiratory rate and oxygen consumption, and decreased blood glucose levels, why in the world do we starve women? Is that evidence-based? Is it appropriate to keep somebody from eating something during labor? Think about that. We'll come back to that question. So here are some early warning criteria, and these are going to be based on policy in whatever facility, but this is some kind of national values. And so if the blood pressure is systolic is under 90 or over 160, we need to intervene. If this is intervention time. If our diastolic blood pressure is over 100, sometimes 110, we need to be concerned. We need to intervene. We'll talk more about that when we talk about abnormal next week. If the heart rate is less than 50 or more than 120, again, intervention. Respiratory less than 10, more than 30. Oxygen saturation at sea level less than 95 is a warning sign. It's not okay. If we have less than 35 mLs of urine for greater than 2 hours, not okay. If you start to see agitation, confusion, unresponsiveness, or a headache that doesn't go away or shortness of breath, those are all early warning signs. And so we need to be paying attention to them. How is the baby responding in labor? Well, we're going to see changes in the fetal heart rate. If you were to do an ultrasound, you would see that there's a decrease in fetal breathing movements. There's an increase in the arterial carbon dioxide pressure. And we will see there's a decrease in our fetal oxygen pressure. This baby is getting ready to make a complete physiological change and move from interuterine circulation to extrauterine circulation, and it's preparing for that. So how do we assess how the fetus is doing during labor and birth? Well, amniotic fluid, that's one of the things we're looking for, watching for signs of infection with odor, watching for signs of meconium, which could be a sign of stress, not always, but it could be. We're going to be watching or using fetal heart rate monitoring. It may be handheld versus continuous. Sometimes it's intermittent versus continuous, and we have external versus internal. We'll talk about each of those. We're going to be looking at the fetal heart rate patterns. Again, this is something that you're going to have to get a little bit of a baseline information on. Once you become a labor and delivery nurse, once you get hired, you will have to become certified in this area. I have an entire video. I highly recommend that you watch it. If you're in my in-person class, you will be watching it. It's on this YouTube list. And the things you need to pay attention to is baseline variability, and changes in that in those things. And what we're looking at when we're looking at fetal heart rate and those criteria is oxygenation of the fetus. How well is it tolerating what's happening? And then a couple of other things that we could do is fetal scalp sampling, pulse oximetry, and stimulation. These are all kind of advanced ideas. Not all areas utilize them, some with more efficacy than others. I'll let you read about that in your book. We aren't doing these two in our local area. So when we're looking at a fetal monitor, up here you can see our normal range is 110 to 160, and that's what this blue line represents. And here is the representation of the fetal heart rate. And as you go through the video that I have been referring to, we'll talk about this at greater length. But overall, what we're looking at, the criteria that we're assessing is baseline. Is it in normal range? What is the variability of that baseline? Do we have good variability, meaning that beat to beat change? And again, see the other video. Do we have accels and do we have decels? And if so, what type? So all of that is what we're looking at when we're assessing a fetal monitor. And it all has to do with how the baby's reserves are and the oxygenation of that fetus. So here's the key terms related to your fetal heart rate. So those are the ones that I just mentioned. And here are the categories. So we like to have categories so everyone is talking the same language. This came out in 2008. This is the nomenclature associated with the NICHD terminology. So I can call a physician and say, I have a category 1 fetal heart rate, or I have a category 2, or I have a category 3, and then everybody knows what I mean. These are the criteria that put you in a category 1. These are the criteria that put you in a category 2, and the criteria that put you in a category 3. So basically what you're saying is, in category 1, I can reasonably assume that this baby is well oxygenated and tolerating what's going on in the uterus. In category 2, I don't know. I need more information. I can't assume either category 1 or category 2. In category 3, I can reasonably assume, based on this criteria, that my baby is not well oxygenated and that intervention is necessary, either by expediting delivery or changing what's going on with our care. So that's what those mean. So when you're talking about this, that's what I was just saying, reasonably certain of appropriate oxygenation and cannot rule out hypoxia. So these are the things that tell me I'm reasonably certain. And these are the things that I cannot rule out hypoxia and will need intervention. I can't just sit on these and watch them. So a fantastic tool, take a snip of this, do whatever you need. If you're not in my in-person class, you want this will help remind you, these terms, veal, CHOP, will help you determine what kind of decel you have and what it means. So there's a great acronym to remember when you're in NCLEX. So if you write down veal CHOP, and then you see that you have a variable decel, you automatically remember that it's cord compression. If you have an early decel, it's caused by head compression. If you have an acceleration of the heart rate, it means it's oxygenated and it's okay. If you have a late decel, it's most likely related to placental insufficiency and we need some intervention. So check out that other video and here's your mnemonic to copy down. Non-reassuring, which is an old term, you'll sometimes see that, but non-reassuring fetal heart tones that are not category 1 and some category 2, you can suspect that we are developing hypoxia or that hypoxia is worsening. That's what we mean. And that's what we're looking at when we're looking at fetal heart rate. Here are your guidelines. I'll let you spend a minute looking at this. You can pause this video. These are the guidelines for assessing fetal heart rate, and this is based on American Academy of Nurse Midwives, ACOG, and AWHONN, Association of Women's Health, Obstetric and Neonatal Nurses. And here are some of those fetal monitor patterns. Again, you are going to see, you're always looking, is it normal range? Do you have accels? What's your variability? And do you have decels? And if so, what type? And here is an example of a written strip. So these are often, well, I won't say often printed, but sometimes these are printed. And if you go to court, these will be printed. And this is showing that this baby is having very little variability, which is that beat to beat change here. It is showing us that it is having late decelerations happening after these contractions, and it is worsening. And you notice that right here is when they turn the Pitocin off, which it makes me very curious as to what was going on back here. Pitocin being the medication that causes uterine contractions, if you've got this situation going on and you're running Pitocin and a baby looks like this, you cannot prove that it wasn't the medication causing this baby to be without enough oxygen. So continuous electronic fetal monitoring, again, this is just why we use it and what the example of it is. I've talked about that quite a bit. Okay, so now we're going to move on into stages of labor. So our stages of labor are 1, 2, 3, and 4. Those are on the next slide. And in those stages, we have different things that are happening. So you can see our stage 1 is when we're dilating and effacing that cervix. Stage 2 is from the time the cervix is completely dilated to the birth of that baby. But in our stage 1, we have lots of things that are happening here. So this is the longest of all the stages. There are 3 phases, actually only 2 phases associated with it now. If you've had a baby before versus not having had a baby before, this will be different. And maternal behaviors will influence how long it takes for that dilation and effacement to take. So current research tells us that we really only have the early latent phase and the active phase. They've kind of done away with this transition phase. That's the very end as we're moving into stage 2. So we'll just focus on latent, which is our early phase, and active. And these 2 phases, this one is the longest, and this one you start to see really big changes happening in that cervix. Once we get that cervix fully dilated, we're going to move on to our second stage, which is the pushing stage. And it's important for you to know what the average lengths of time are, because what we've seen on TV, or what we assume, or what our prior knowledge tells us, is that these things happen very quickly, but they actually don't. If we leave a woman to her own, on her own, the average length of labor for a first-time mom for this first stage is anywhere from 12 to 24 hours. And the average length of pushing for a first-time mom is anywhere from 30 minutes up to 2 hours or 3 hours if she's unmedicated, and up to 4 hours if she has an epidural. So these things take time, and that's where that patience comes in. So this is just a picture. There's your latent and active. So this is evidence-based. This is what we're using now. And these are just some pictures of what it looks like, how a mom might be feeling. And then we get to our third stage. So the baby's been born, and the third stage is placental separation and placental expulsion. And then our fourth stage, this is the time when we as nurses need to be the most diligent about watching our moms and babies, is that recovery period up to 4 hours after delivery. So here's the placenta. This is the fetal side, and you can see that's turned inside out. This is where the umbilical cord is attached, and this is the sac that the baby was living in. And here's the maternal side. This is what was embedded into the uterus, and oftentimes you'll see the provider, sometimes a nurse, will pick this up with gloves and kind of hold it all back together to make sure all these codlins there's no big pieces or chunks missing, because if that's the case, they might be left inside the mom, and that could cause us some issues. We'll talk about that later. So the signs that the placenta is starting to separate and getting ready to come out, the uterus is going to rise upward, the umbilical cord is going to lengthen, we might have a sudden gush of blood from the vagina, and the uterus is going to change shape. Once the placenta comes out, that's when we are going to be assessing that fundus, and as we move into our postpartum lecture, we'll talk more about that. Other factors that may affect labor and how long those stages and phases take are the size and position of the baby's head, the presentation of the baby, the size and shape of the mother's pelvis, how effective those contractions are, if she's exhausted or not well hydrated or not fed well, not well nourished. That can affect the strength of her contractions. If she's been doing it for a long time, several days, her uterus is going to tire. Her emotional and physical state are going to affect how long these stages and phases last. Whether she feels supported, if the birth partner is providing her with the support she needs, and whether she's using medications or anesthesia. So other things that are going to influence your pain during labor and birth are physiologic. Everyone has a different pain tolerance. Spiritual, how you feel about pain. Psychosocial, cultural, and environmental. So all of these are going to influence, and you're going to see some people are very stoic and don't have aren't very vocal, and others are extremely vocal, but still managing and tolerating what they're experiencing. So it's a universal experience. The intensity is highly variable. And with every pregnancy, the intensity is highly variable. We do have a mandate for a pain assessment in all clients that come into a healthcare facility. So we have to assess that pain. A lot of times you will see in birth plans, women will say, don't ask me how my pain is. I'll tell you if I need something. Well, unfortunately, we have to ask. And there are non-pharmacological as well as pharmacological choices. And we're going to go through that next. So as we're talking about our non-pharmacological pain relief, again, I think this is one of the things that we don't spend enough time on. And as labor nurses, this is essential. You will have to spend some time learning and practicing and using these non-pharmacological relief measures. It is part of our job. So continuous labor support, even just having someone there continuously, has been proven to decrease a woman's perception of pain, decrease the length of labor. And so that might be a partner, or it might be a doula, which is a non-medical professional that they hire to come and offer support during labor. Doulas have been around for centuries. In fact, some of those pictures that we looked at before, some of those women most likely were doulas. And if you're going to be having a baby, you certainly should look into that option. If you are a nurse, consider yourself lucky when you have a doula in the room, because they're going to help you and they already have a rapport with this patient. And it's beautiful when you can all work together. Ambulation and position changes. One of the most important non-pharmacological pain relief measures we have. Women were not meant to labor in bed. We are not designed. If you leave a woman on her own, any primate on their own, the last thing they're going to do is get on their backs in bed and put their legs up in the air. That is not going to happen. So we need to encourage them, even if they have continuous monitoring required for their condition. We need to encourage them up, out of bed, use peanut balls, move around. This is important. Sometimes people use acupuncture and acupressure. Obviously, they need to be trained in these techniques. Attention focusing and imagery, that's kind of your Lamaze method or Bradley method, where you're focusing on something other than the pain, using your breathing techniques. Therapeutic touch and massage, and effleurage, which is just a very gentle light touch. All of these, and hydrotherapy, all of these are hugely important in labor. And if we can decrease her pain and decrease her perception of pain and how she's dealing with it, we can decrease oftentimes the length of her labor. This is just a coping with labor algorithm. You can stop the video and take a look here. It just tells you some clues. Is she coping? Is she not coping? And some ideas of what to do for both of those categories. If a woman is successfully using something that is safe and is working, do not interfere. I've seen women do all sorts of coping techniques. Sometimes they'll count out loud in a very rhythmic fashion. Sometimes they'll rub a silky shirt or blanket or something that they find in a very repetitive motion. Sometimes they'll rock back and forth. Sometimes they'll hum. Sometimes they'll cuss. Sometimes they'll yell out loud. Sometimes they'll sing. Whatever it is that they're doing, sometimes they'll tap their foot. Let them find their own coping technique. Don't interfere. So you can tell how someone is coping based on their non-verbal communication tools, right? Obviously, this woman is very zen about what's happening here, and this woman is not coping well. So what you as a nurse might do is go to this woman, wait till this contraction's over, and very quietly get close to her and say, let's try to relax in between this contraction. Let's take all that pressure out of your face. Let's maybe change your position. And when the next contraction comes, I want you to breathe through it. Just in through your nose, out through your mouth, and help her get out of this state, because the sooner you can get her out of this state, the better she will be. And hopefully we can get her back to that state. Here are those birth balls that I was talking about. Many units have these on the unit nowadays. They can be wiped off. We can put chucks on them and or cover them with a gown and make sure they're nice and clean. But women being upright, opening their pelvis, helping this baby to move into the optimal position will shorten her labor and decrease her pain and decrease her chance of having a cesarean section. If she's in bed, if she already has an epidural, if she has to be in bed for some reason, we can use these peanut balls. These are amazing at helping getting these babies into the correct position. Here is another example of using a peanut ball. There's some really fantastic videos. I have them on my YouTube list, on my video list. Spend some time there if you want to learn more about these techniques. The breathing patterns. You can tell by this woman what her breathing pattern is. It's hyperventilation. If she continues on with this, eventually she will start to have her hands claw up, her feet might claw up. She's going to feel lightheaded and dizzy and eventually will pass out. So you don't want to let them use this breathing pattern. There are lots of different types of rhythmic breathing patterns. My favorite is just in through your nose and out through your mouth slowly. Works for lots of things. This is how you recognize that hyperventilation. These are the things I just mentioned, and this is how you would correct it. These are all little tips that you can use if she is hyperventilating, trying to help them get back into control before they pass out. Now we're going to move on to our pharmacological tools, and our options are systemic, regional, or neuraxial. And so systemic, this is actually systemic. This is nitrous oxide. This is what they called gas and air 100 years ago. The midwives and Call the Midwife used to bring their gas and air machine, and nitrous oxide is laughing gas, commonly referred to as laughing gas. Some people use it when they go to the dentist. It's a different concentration when you go to the dentist, but it's a very effective tool in controlling anxiety in labor. And some women find it's the anxiety of it, not the actual pain. So the beautiful thing about nitrous oxide is that the woman controls it by holding this mask against her face. No one else can do that for her. She has to do it. And so it looks like the nurse is holding it, but actually the nurse just has her hand on her shoulder. There are essentially no changes to the fetal heart tones and no side effects with this. It has to be used cautiously with vitamin B12 deficiency. And so if you have somebody that is a vegan, you do want to make sure that their vitamin B12 is appropriate. And if someone has some of the disease processes that go along with vitamin B12. But this is a very effective tool. It can be used all the way up and during labor. I mean, during pushing, during delivery, during repair. It's a beautiful tool. The minute she takes it off of her mouth, it clears the body in about 30 to 60 seconds. So other systemic analgesia would be some of the drugs that we use. Most often the medications that are used, and look at your medication list, but sometimes you'll see Stadol, Nubain, and fentanyl. Occasionally you'll still find some questions and or some resources that mention Demerol, which is meperidine. We don't use that in labor anymore. Hasn't been used in labor in about a decade. You don't see it in the hospitals much at all anymore. So we do not use it in labor. These are short acting, and there is a maximum amount of doses that we can give. Everything we give to mom, we're also giving to baby. So the side effects for mom might be sleepiness and decreased respiration. So we need to have an O2 sat on to know what's going on with this mama. And then for our baby, we're going to see decreased variability and potentially respiratory depression if it's given too close to delivery. So we try to predict how things are moving along and not give these medications too close to actual delivery. The other regional anesthesia that we can use, epidural block. This is a continuous infusion. We sometimes will use a local, usually for repair of the episiotomy or the tear in the perineal area. Occasionally, you still see people using a pudendal block, which is basically a local way up into the vagina. And it's usually used for second stage episiotomy or operative vaginal delivery. And then we see a spinal or intrathecal, which is most commonly used for cesarean birth. So here's an example of what it looks like when they are putting in an epidural. This epidural catheter has to have, the needle is large enough so this catheter can actually slip through it. It's called an forgot the term. So it looks huge, but it's because this catheter has to slip through it and then they pull the needle off the other side of it. This epidural is put in either by a anesthesiologist or a nurse anesthetist that has been trained in this procedure. And you can see it's called an epidural because it just goes into the space above the dura. It does not get to the spinal cord. It does not puncture the dura. And then this catheter is frequently left behind and the needle is removed and this is taped down and it's just in there a few millimeters. It's not in there very far. And it delivers a medication, usually a combination of some sort of pain relieving like fentanyl and some sort of numbing like Sensorcaine, or there's a few others that they use. So this is a continuous drip until the baby is born. It numbs the woman most often from about the nipple line down. We don't want it to be so numb that she cannot have any feeling in her legs or perineal area because she needs to be able to feel to push. If she's going to have a spinal for a surgery, the procedure looks similar, but it's actually pretty different. They use a very small needle and they do puncture into the dura and just put a little bit of medication there and then pull everything out. Nothing's left behind. And that gives a heavier block and allows for just a short duration of time because they know they're not going to be in surgery forever. So it lasts for a shorter duration. This is what it looks like as that procedure is actually happening. This is the role of the nurse to help position this mom. She will need to relax these shoulders and open up the space because they do have to, you can see on this picture, they do have to get through these bones in between those bones. And if you can open this space, it's easier for the practitioner to get in. So the nurse's role is, obviously, we're assessing how the mom's doing, keeping her calm. She's still going to have contractions during this time, but she also needs to help her relax and push her back out like a mad cat. The benefits is it provides good pain control for most women. There are side effects to it. It often causes a decreased blood pressure. And so with that vasodilation and a decreased blood pressure, sometimes moms will be symptomatic. And so our intervention is to provide a bolus of fluid concurrently at the time that she's getting the epidural. There are still some facilities that are doing it prior, but the evidence tells us it actually is more effective if it's done concurrently to the actual procedure. And then there might be a need for some vasopressors like ephedrine to bring up that blood pressure if she's had a pronounced vasodilation and she's symptomatic. We also see that there is decreased maternal movement after an epidural, and that increases our chance of having fetal malpresentation. So our nursing intervention there is to reposition, use peanut balls. Let's get her moving every 20, 30 minutes. We need to simulate what it would have been like if she had not had the epidural and keep her moving to encourage that baby to be in the best possible position for delivery. So the difference between analgesia and anesthetic, analgesia blocks pain, anesthetic blocks both pain and motor response. So you can't move. So continuing our assessments in our first stage of labor, again, we want to know what her knowledge is, what her expectations are, vital signs, give her information on labor progress. We're going to be documenting her labor progress, uterine contractions, pain level. How well is she coping? That's our job to be documenting that. We're also going to be looking at the fetal heart rate and our amniotic fluid. All of this is our job along with helping her through the process. So we are documenting and reporting anything that needs further intervention here. In the nursing management of our second stage, this is when she's pushing the baby out. We're looking for those signs What are the signs that this is starting to happen? We might see low grunting sounds. We might see spontaneous pushing. We might see increased bloody show. Her contractions might space out for just a minute and then come back very strong. If her water is not already broken, she might have spontaneous rupture of membranes. That's what this acronym is. She might be increasingly irritable or apprehensive as she moves into this different stage of her labor. We're going to be watching those maternal vital signs during pushing. We're going to be watching the fetal response during pushing. Again, how well is she coping and how well is the partner able to support her? Our nursing management is providing instruction, being at the bedside, helping her, giving her ideas for moving, turning, getting this baby into the best possible position, and getting ready for the assisting with delivery. So these are some different ways of pushing. What you might see in the hospital is a whole lot of laying on your back in that traditional lithotomy position, pulling those legs up, spreading those knees wide. And I'm here to tell you, none of that is based on evidence. And if you use some of the tools that we learn in spinning babies and just with experience, you'll know that having this mom turn in different positions, opening that pelvis, closing those knees, this will help you to get that baby down and you will have less pushing. It's called a squat bar and you can use it for lots of things. The most maternity beds come with this. They have a hold that this sits right into. So if you don't know where your squat bar is on your unit, you need to find it. Here are some other ways that you can utilize the bed for appropriate pushing. And then our nursing interventions for actual delivery is depending on hospital policy, cleaning the area, making sure that we are watching for complications, documentation, protecting her environment. If that, you know, a lot of people get really excited during delivery, and sometimes it can sound like you're at a sports game down in the South where everyone's yelling and cheering and clapping, and the mom is just overwhelmed by all the stimuli. Somebody needs to take control of that room and say, okay, one person's going to talk. Let's let her focus on what she's doing here and really protecting that environment. Providing immediate care to that newborn, performing an APGAR. We'll talk more about that. Drying that baby off. Neonatal resuscitation is another certification that you will have to do once you become a labor and delivery nurse or working with babies in the NICU. And then we need to identify that baby and the parents by putting their identification tags on. Once the placenta has come out, depending on your facility, the nurse may be involved in looking for any missing pieces and parts. We are going to be paying attention to any perineal trauma, possibly treating it with ice immediately if we can. That will help decrease the swelling. Sometimes you will have medications that need to be given. This is when there's the potential for excessive bleeding. We'll talk about that in another lecture. We're going to provide warmth to the mother and the baby. It's very common for them to be very shaky at this point. They've had a large fluid shift, and so sometimes it can be very pronounced, and a warm blanket is comforting. It's not because she's cold that she's shaking, but it is comforting. And then we're going to do a calculation of the quantitative amount of blood loss. We're going to be performing an assessment every 15 minutes for a minimum of 2 hours. And that assessment is going to include vital signs. The fundus, where is it in the body? Is it firm? And what's its relationship to the umbilicus? And then we're going to look at her comfort level, what the lochia or bleeding status is, and her bladder status. And then all of these things, these are the interventions that we're going to be helping her with. So our job is not over once that baby is born. In some places, you will have babies that stay on the mother-baby unit, and it's also a postpartum unit. And most places have moved to more of a postpartum unit where they go to continue their recovery and then be discharged. And of course, this little sweetie is what it's all about. Thanks for your attention today. If you have questions, reach out.